Welcome to Performance Around the Clock, where we explore the latest research on how to keep our body and mind at our peak physical, emotional, and intellectual performance around the clock. I am your host, Professor Satchin Panda at the Salk Institute, La Jolla, California. On this podcast, we'll talk to leading scientists, clinicians, coaches, and policymakers about human performance. We'll cover different topics, including how different organs and different parts of the brain contribute to human performance. And we'll also learn how our lifestyle, that is, what, when, and how much we eat, sleep, and move around every single day affect our health and wellness. I hope you'll join me in this journey to explore new knowledge and adapt it in our own life to improve our health and wellness throughout our life. Welcome to another episode of Performance Around the Clock. Last time we discussed how heart health is at the heart of our health. And when we think of heart health, almost everybody who goes to get their annual checkup done, then they usually get what we call lipid panel. That is cholesterol, LDL cholesterol, HDL cholesterol, triglyceride. And some people actually get NMR lipoprotein profile, which is a little bit more in-depth analysis of their cardiovascular disease risk. And what we all know is we know these numbers are important, but we don't know really how cholesterol, LDL cholesterol, HDL cholesterol, and all of these things lead to, when they have excess of it, then how that leads to risk for cardiovascular disease or stroke. So I thought it'll be really cool to have Elizabeth Epstein, cardiologist, to sit down and explain all these things that she does on a regular basis to many of her patients. So that's why I thought this will be a great episode on cholesterol. And then, if there is time towards the end, she has some really cool techniques with portable ultrasound. She can demonstrate how to measure cardiovascular disease risk by measuring atherosclerotic plaque. Or maybe she can correct me. You can correct me.
Exactly.
Yeah. So welcome.
Thank you.
Yeah.
Thanks for having me back again.
Yeah. So every time, I remember a long time ago when I was a grad student, I went for my first annual checkup. Full disclosure, just like many young people out there, I thought that I am invincible, nothing can touch me, and I should not go for my annual checkup. But out of curiosity, I went. I got these numbers: LDL cholesterol, HDL cholesterol, and triglycerides. And for a long time, I actually didn't pay attention because I was in the healthy range. And then I realized that, well, being from India and being Indian male, many Indian males are actually at a high risk for cardiovascular disease. So then I started paying attention. And I realized that these terms are very confusing. And we sometimes think that cholesterol is bad, lipids are bad. But they have some function. So let's dive deep into it. And so, Liz, when someone goes to get their, I would say, garden variety metabolic panel, what are the things they usually test?
So usually the traditional lipid panel, you'll get a total cholesterol, LDL cholesterol, HDL cholesterol, and triglycerides on there.
Mhm.
I will often order the NMR lipoprofile, which will give you your particle numbers as well as some other things. But your garden variety, you'll get that lipid panel with the total cholesterol, LDL, HDL, and triglycerides.
Okay. So please walk us through what is cholesterol and is it good or bad? What is it? Why do we need cholesterol? And
Yeah. So your body has this system for maintaining the proper level of cholesterol, which is a fat, because fats are really important for forming our cell membranes and for building vitamins, building hormones. And so they need to be taken up. They're one of our nutrients that we need, taken up from the gut and carried around the body to deliver to different tissues. And then your liver is kind of the house for determining the proper levels in the body, and it makes cholesterol, but also gets rid of cholesterol. So the liver is kind of the hub for that.
So cholesterol gets broken down to various things, and I think one of them is bile acids, which gets into the gallbladder and then again released into the intestine to pick up more fat, right?
Yes.
Yeah. So even to absorb fat, we need breakdown products of cholesterol. It's kind of a positive loop. What are the other things? The steroid hormones also come from cholesterol breakdown products?
Exactly. Vitamin D is another one.
Yeah.
And so it's really necessary in the body, and we've got some specified mechanisms in the liver to make sure we've got that right amount inside cells for the use of the cell. So it starts in the gut, where you've eaten some food that has fat in it and cholesterol in it, and the intestine cells will take that up and package it. Because as we know, when you put oil in water, it's lipophobic or hydrophobic. And so you can't just have that. You need to have it packaged in order to carry it around the body. So it gets packaged with a protein, and it's called a lipoprotein. And that's what LDL and HDL, they're all lipoproteins. They're lipids with a protein, and it's a package.
Yeah, so low density lipoprotein, LDL, and then high density lipoprotein. So in the intestine, all these cholesterol, proteins, and lipids, or the fat-like molecules, they get together and they get absorbed. Then what happens? Are those LDL or those are something else?
Not yet.
Yeah.
So it gets packaged into chylomicron, which is a big lipoprotein. I think it's the biggest lipoprotein that gets made in the gut, in the intestine cells.
Yeah.
And that gets transported around the body, and your tissues will use that and take the triglyceride that's packaged in that chylomicron through lipoprotein lipase. So they'll use an enzyme to grab some of the triglyceride from it. And then the chylomicron gets, as you chip away at it, is kind of how I imagine it, it becomes a chylomicron remnant. So it's a smaller lipoprotein now that ends up floating its way back to the liver and getting degraded there.
So the triglyceride, so this is 3 tri and glyceride on a glycerol molecule. There are 3 fatty acids or fat chains. They're hanging onto it. So
you get fatty acids from your diet.
Yeah. So so this also relates to what we call triglyceride in the blood, because one of the parameters that we measure in the blood, in the lipid panel, garden variety lipid panel, is triglyceride. So the more triglyceride in the blood means there are more of these lipid-like lipoprotein particles floating around.
Yes. So the different lipoproteins package in both triglyceride and cholesterol.
Yeah.
And some have more triglycerides, some have more cholesterol. LDL has been our main focus as a driver of cardiovascular risk because it's the lipoprotein that carries the most cholesterol packed in.
Oh, I see.
So most cholesterol in the body is packed into the LDL, whereas other lipoproteins like chylomicron or VLDL tend to be more rich in triglycerides.
I see.
And when you get the triglyceride level on your lipid panel, you're measuring the mass, the total mass. You're not looking at the number of particles. You're saying in all these lipoproteins, what is the mass of triglyceride that's in the blood?
So I'm just curious. So in the morning, if I have a big steak and then go for my lipid panel, I would have too much of chylomicron floating around. And since there is more triglyceride in chylomicron, if I get an abnormally high total triglyceride, then that may be due to my diet that I had.
Yeah, triglycerides tend to be the most reactive to your day-to-day diet. So
I see.
that's the one that if you ate before it, we will see a difference. We would expect to see a difference in triglycerides. And we actually are preferring to get a non-fasting triglycerides now. It used to always be get your fasting labs.
Yeah.
But we're very interested in what does your triglyceride look like when it spikes after meals. So
I see.
So we will see a spike in relation to the diet, and can be fatty, but also triglycerides can be raised by carbohydrates in the diet as well.
Okay, so triglycerides are also essential for our body, right? Because these fats are chipped away and different cells, different parts of the body actually needs them. So then the chylomicrons that get chipped away, it's almost like a kind of, it's a candy. You are kind of eating it and slowly it gets smaller and smaller. And then as it's floating around, then it gets taken up by the liver.
Yes.
Yeah.
Taken up by the liver, and the lipoprotein degraded, and the cholesterol that's left inside released inside the cell, and for use inside the cell.
So are there specific mechanism or way? Because anything that gets into the cell, either it gets into the cell through a pore or channel, or a receptor that binds and then takes it in.
Yes. Yeah. So the LDL receptor is one that we may have all heard about.
Yeah.
That binds a lot of the lipoproteins and is as part of taking them into the liver through endocytosis.
Yeah. So if the LDL receptor is defective, then all that LDL, the chylomicron remnants or LDL would float around in the blood.
Exactly. It's directly related to, that's one big part of it, is how many LDL receptors do you have on the surface of the cells in the liver that will directly, you can imagine if you have twice as many LDL receptors, you're going to have half as much LDL cholesterol in the blood. And that's an interesting thing that we see with women, is that they lose half their LDL receptors on the hepatocytes after menopause. And so we do see quite a big rise, almost doubling of cholesterol in women around that time. And it's related to the LDL receptors.
Oh, so I didn't know that. So hepatocytes are liver cells. Right?
Yes.
And as women hit menopause, that's when it happens?
Yes.
So they reduce the number of LDL receptor?
Exactly.
Do men have same number or less number of LDL receptor than women before menopause? Is there any difference?
I don't know about the difference of receptors before and after for men and women.
Because I always hear that men, before the age of 50, men are more likely to have cardiovascular disease. But I'm not sure whether it's because of LDL pathway, or we also know that they are at a high risk for pre-diabetes at a younger age. Yeah,
when the men build plaque earlier, and then women. So I would guess that men have less LDL receptors to begin with. Maybe women have double because of estrogen and hormonal reasons, and then it lowers after menopause. That would kind of make sense of those.
Yeah, but anyways, I will look up to see that, because it just occurred to me that even last time you had mentioned that men are more likely to build up plaques before 50, whereas women usually delay the plaque building. So that's why I was curious whether before 50 men and women have different LDL receptor. And are there then genetic conditions where LDL receptor may be mutated, or are there conditions that people should be aware of? Yes.
So some of the main genetic causes for very highly elevated cholesterol that leads to plaque buildup very early in life are due to mutations in the LDL receptor.
And how frequent is that? Like 1 in 1,000, 1 in 100, 1 in a couple of hundred, something like that?
I don't have the exact number in mind. It's fairly rare to have the homozygous familial hypercholesterolemia, but fairly common in my clinic do I see a heterozygous familial hypercholesterolemia. And that one is really diagnosed with the total cholesterol above 300.
I see. So you do see some people who still come with total cholesterol above 300. So the last time you mentioned that there is no safe limit of cholesterol because it all depends on many factors. But typically, what most cardiologists would consider safe is what? 200? 100?
It's hard to give an exact number
Yeah.
because I was just
What is the AHA recommendation?
Yeah, I mean, I think less than 100 LDL cholesterol in general is a good thing to aim for.
Yeah.
But it's definitely more complicated than that.
Yeah.
The average cholesterol of a patient with a heart attack is 130.
Oh, really?
So it's within that normal range.
Yeah.
So it's a lot more complicated than just making sure you're in that normal range. And I was just talking about a case with a colleague yesterday of a patient who had very run-of-the-mill LDL cholesterol, but a very calcium score over 1,000.
Oh.
A young patient, and it just goes to show you that you have to look at the whole lipid panel together. And for him, I think it was the triglyceride risk. And having a fasting triglycerides of 200, and that drove that. So I think aiming for an LDL less than 100 is a good thing for everybody, but doesn't mean that you are 100% safe.
Yeah. But at least what you're saying is there are, in your practice, when you're seeing patients who are walking in with more than 300 and they're likely to have at least one copy, out of two copies, when one copy is defective, that's heterozygous mutation.
Exactly.
And I guess once, somewhere I read that it's almost 1 in 150 or 1 in 200, in that range, people actually have this familial hypercholesterolemia. So that means, in your graduating class, there might be 200 students, at least one of them might have hypercholesterolemia. Similarly, if you're working in an office, if you know 100 people or 200 people, or among your extended family, there might be one. So it's not that rare. It's actually quite prevalent.
And that's important to diagnose because it means that since you were a baby, your body has been exposed to these abnormally, astronomically high levels of cholesterol. And these are the people that build plaque very, very early in life and need a very aggressive upfront treatment to plummet the cholesterol down and keep it down.
So this is another reason why even teenagers should get at least once in their teenage years a comprehensive metabolic panel, comprehensive lipid panel, and all these tests done to catch at least this one of the familial, means we're talking about only LDL receptor mutations, but there can be mutations in many other components in this entire cardiovascular spectrum.
Yes.
Glucose, triglyceride, lipids. Okay, so we got a little distracted there, but the point is LDL receptor is the key for mopping up all the cholesterol and LDL particles, and is an important regulator.
It's like the filter.
It's the filter. So once these particles get into the liver, then the triglyceride or the particle has some lipids, some protein, some triglyceride, 3 fatty acids or triglycerides. And then in the liver, you mentioned that the cholesterol may be used for some of the breakdown products.
Yep, exactly.
Like bile acids.
Yes, it can go into the bile.
Yeah, or various hormones. And then what happens in the liver? You also mentioned liver makes some cholesterol.
Yes. So the liver has, the hepatocytes have almost like a thermostat inside of the cell that's trying to make sure you have enough cholesterol in the body because it has important functions that we talked about. And so you have your thermostat, and if the levels aren't high enough inside the cell, then the liver actually starts making cholesterol. And it packages it into the LDL, another lipoprotein. And that lipoprotein will travel around and get bits taken off of it by different tissues, muscle, peripheral tissues. and becomes IDL and
I see.
then LDL.
I see.
And they all have, what's the difference between them? There are different size of the particles, different amounts of triglycerides, different amounts of cholesterol. And as I mentioned, the VLDL has a lot more triglyceride,
Mhm.
and the LDL has a lot more cholesterol.
I see. So in the liver, when there's actually from circadian point of view, what we know is many genes that code for enzymes that make cholesterol. They're regulated by both circadian clock, so that means their levels go up or down at different time, and also by fasting. So HMG-CoA reductase, HMG-CoA synthase, those are the last two enzymes for making critical enzymes for making cholesterol. They actually cycle. So as a result, I think, and those are also the enzymes that are targeted by statins.
Yes.
Yeah. So statins, how do the statins then work? So we went from mutations in LDL receptor.
Yeah. So this system with the thermostat.
Yeah.
So the thermostat controls how much cholesterol is made by the liver,
Yeah.
but it also controls how much LDL receptors are sent to the surface of the liver cells.
To capture more.
All designed to get more cholesterol inside the cell. So we've learned that we can target these areas and kind of hijack that thermostat system in order to lower the LDL cholesterol that's in the bloodstream. And so one way through statins that block HMG-CoA reductase, which is that critical enzyme in building cholesterol in the liver cells.
Mm-hmm.
So they block that, and then inside the cell, it thinks we don't have enough cholesterol in here, so we better take it from the blood.
Mm-hmm.
So it sends more LDL receptors to the surface to bring more cholesterol in.
Mm-hmm. I see. So then, so that's how statins work. So then going back to this familial hypercholesterolemia, where the LDL receptors are not fully functional. Mm. So statins may not work in that case because are not as effectively as in normal people. Is that true? So people who are have extremely high level of cholesterol, statins,
they still work to some degree.
Some extent.
And have to use other additional medications with that.
Because they already have one good copy of LDL receptor, mm-hmm. So they will still work. So and then what we have seen in our research on time-restricted eating, or what people say intermittent fasting, is when these mice, of course, we can do these studies in mice because we can take out the liver and look at what is happening. There is an enzyme that breaks down cholesterol called cytochrome P450 CYP7A1 mm-hmm. in mouse. And this enzyme, the gene for this enzyme, it turns on in response to fasting. So under fasting condition, it turns on, and then it breaks down some cholesterol, makes bile acids, and then that bile gets out into mm-hmm. the intestine. So it's kind of interesting. This is where the intersection of fasting, statin, circadian rhythm, all of them converge on this mm-hmm. cholesterol and LDL pathway.
Yeah. And I've heard that most cholesterol is made while you're sleeping.
Yeah. So because the HMG-CoA reductase, that enzyme is strongly circadian. Mm-hmm. And that might explain why some statins work better in the evening, because when cholesterol is being made, you're essentially inhibiting it.
Hitting it right
at the right time. Yeah. So then liver produces VLDL, and then that goes out and
gets chipped away at, becomes IDL, becomes LDL. All with different concentrations of triglycerides and cholesterol inside.
So that's why having a low cholesterol diet might help people who have high LDL cholesterol level.
It's part of it. We used to say for a while, we said, oh, it's not the cholesterol in your diet. It's really the cholesterol that your body makes. And it's the amount of overall fat in the diet and saturated fat rather than looking at cholesterol like from shrimp. Or eggs. A big debate has been over eggs over the years. But now, we know that we do absorb some of the cholesterol from the diet. So people who are eating very high cholesterol diets, we do see a rise in cholesterol from them.
Yeah.
So we do recommend limiting cholesterol and also limiting saturated fat as well.
And how do these LDL particles or VLDL particles lead to plaque?
So that's an interesting story. So in the coronary arteries, usually at some vulnerable spot, maybe a twist or turn where there's increased shear stress on that area, those...
Coronary artery is the main artery that comes out of the heart.
The coronary arteries there are 3 main coronary arteries, and they come off the aorta, which is the big pipe that comes out of your heart. And they actually go to the heart muscle and supply the heart muscle with the blood and oxygen that it needs to function normally. And so it's plaque in those arteries that ends up causing a heart attack potentially. And so these ApoB containing lipoproteins, we know that those are the ones that really cause heart disease. They cause...
ApoB is the protein.
It's the protein, yes. So the thought is that it's these ApoB, and so you've probably heard a lot about ApoB, measuring ApoB, and thinking about ApoB as a very good marker of risk, which we know that it is. And so these ApoB-containing lipoproteins will slip into the wall of the coronary artery and get stuck there. And then they get eaten up by a macrophage, which is an immune cell, and then it becomes a dysfunctional immune cell. You get a lot of inflammatory reaction happening there, and it forms a plaque. And I envision the plaque, it's kind of like a pimple on the wall of the coronary artery. And as a pimple on your face, it contains gunk. And there may come a point where that pimple grows exponentially and ruptures, releases the gunk, which is sticky. Platelets stick to it, clot forms, and a heart attack happens. That's the worry.
So when these plaques rupture and then block a capillary, small blood vessel in heart, then that part of the cardiac muscle cannot contract and cannot expand. So that's what happens. So is it possible that these plaques can occur in other parts of the body?
Yeah, it is 100%. And so I always tell people, we have incredible technology, stents, bypass. We're able to really save people in the here and now when a heart attack may happen. But then when I see them back in my clinic and want to talk about prevention, I say that it's a systemic disease. Because if you have plaque somewhere, you likely have plaque somewhere else, other spots in the coronaries. And we know that it's oftentimes not the narrowest plaque that ruptures. It's actually one of the smaller plaques, which are more prevalent.
I see.
That ruptures. So we actually need to treat the whole body. Or you could have plaque in the coronaries, you could have plaque in the legs that could cause pain in the legs one day if it gets too narrow. So it's really treating the whole body. And the good news is that our treatments for ASCVD risk reduction through lipid management, blood pressure, diet, exercise, they all treat the whole body.
I see. So it's possible that these plaques can be even in your kidney, and the kidney will be dysfunctional or may not work well. Almost any organ, it can happen. So as you mentioned, if it happens in the leg, then people might get some leg pain.
Exactly.
They may not be able to climb stairs, so they feel it. And when it happens in the brain, that's what
a stroke.
So
exactly.
So it's this. The risk is the same. It's a buildup of excessive gunk. And when it happens because our heart is constantly beating,
Mhm.
there's the only, I guess, it's the only muscle that actually keeps working from the day we are born until the
Yeah.
day we die.
It-
There's no rest for this muscle.
That's why it's the coolest organ.
Yeah. I mean, you can stop eating for 24, 48 hours, and your the small intestine or intestine is still a smooth muscle, but it doesn't have to work. And
the fact that every cell can beat on its own,
yeah,
has its own electrical signal, it's pretty cool.
yeah. So that's what I've so then you can measure how does calcium get into this? Because the last time I went to get my annual checkup, my primary care physician said, well, it's time for you to get a coronary artery calcium score. So what is calcium? How does it get into plaque? And what is a CAC score?
Yes. So you know how when there's inflammation, chronic inflammation in the body, almost like in a knee joint, someone who has osteoporosis in the knee, it ends up getting calcified. So the same thing happens in the coronary artery. There's chronic inflammation there for a very long time. It gets calcified. And so we'll often see that in someone, these people with heterozygous familial hypercholesterolemia, they may come in with a very calcified plaque that's been going on for a really long time. We don't have a really totally clear understanding of why some people calcify one lesion and why someone may have a soft plaque lesion. We don't fully know yet, but we do know that we can measure the calcium outside all the coronary arteries with the calcium score, and that it's a very powerful tool for risk prediction.
I see. And how does that CAC imaging, or what are you measuring? How are you measuring?
So we do a CT scan of the chest, and it occurs in a single heartbeat.
What is that, a CT scan? I'm sorry, I'm just asking you.
It's basically like an X-ray.
Okay.
It's the same technology as an X-ray, but you're getting a slice through all the slices through the heart at once, so you can scroll through it and see the whole.
It's a soft X-ray, it's a soft X-ray.
Yes.
Because if it is the hard X-ray that for bone, then you won't see the heart, right?
Yes. And so we basically look at the heart and the arteries, and we count up every speck. They actually zoom into the pixel level.
Wow.
And they count up every speck of calcium and create a score. And that is your calcium score. Normal score is 0. You shouldn't have any calcium, and it goes up to the thousands.
Thousands.
And so we have started using this as a very powerful predictor of risk. So we know that if someone has quite a bit of calcium in all 3 coronary arteries, the risk is almost equivalent to if we had done an angiogram and found plaque inside all 3. So it allows us to put the patient on that scale of very low risk all the way to high risk using this non-invasive. It does use radiation, but very low radiation, about a third of a mammogram worth of radiation. So by counting up all the plaque, we can get a good idea of risk. But it's plaque on the outside of the coronaries that this scan is looking at, not on the inside.
Yeah. And then the angiogram does inside?
Angiogram looks on the inside. We can do a CT coronary angiogram.
Okay, so how does it work? You inject something? Or?
Yes. Okay. It's almost the same as an invasive angiogram where we inject contrast inside the coronaries and take a picture inside a single heartbeat. We can reconstruct the coronary arteries and get a pretty good idea of degree of stenosis on the inside because we gave contrast. A little more radiation than the CT calcium score, 1.5 mammograms for the CT with contrast. And then the gold standard is an invasive angiogram where we go in through the wrist, we use wires and tubes to go up to the heart, and we inject a little bit of dye inside the coronaries, and we use live X-ray to evaluate for blockages. And we look in multiple views so we can try to get a sense of this 2D structure in a one-dimensional plane.
But this is not for annual checkup.
This is not for annual checkup. This is more advanced cardiology things
Yeah.
we've gotten into. But the point is that the calcium score counts up all the calcium on the outside of the arteries, not on the inside. And it's a very powerful risk prediction tool.
Yeah. So every year, one should get the lipid panel. And then one thing that we haven't discussed is this NMR lipoprofile that I'm getting it almost every year. And what is an NMR lipoprofile, and who should get it, and how frequently one should get it?
I think if it's feasible with your insurance, it's very helpful to get it at least once, because we can take a look at the LDL particle number and the HDL particle number in relation to the LDL and the HDL and get more information. So there's been some work done on discordance between the LDL and the LDL particle number. So normally the LDL particle number should be about 10 times the LDL. When it's out of proportion high, then there's more risk with the LDL particle number, and we should follow the LDL particle number. When they're concordant, well, then you could follow either, and you're not going to miss risk. But let's say your LDL is 100, but your LDL particle number is 1900, then you're missing a lot of risk by just looking at the basic LDL on the cholesterol panel.
So the particle number is how many tiny particles this LDL is packaged in.
Exactly. The LDL measures the mass of all LDL.
Yeah.
But the LDL particle is counting up all the particles. And you can imagine that it may be that it's actually the number of particles that plays into how many end up going into the artery wall. So it can be very important, the LDL particle number.
I see. So it's almost like, when I always imagine the tea strainer. I use a tea strainer. So if I have, big tea leaves, then those leaves are not going to clog the tea strainer, those tiny pores. But if I have powdered tea powder, then they're more likely to go and clog those holes. So the particle number is like that. If the same amount of tea in pure leaves versus same amount of tea in tiny particles, and whether those ones will go and clog my...
Yeah, and it's almost like statistics. It's like, well, there's more of a chance. If there's more particles floating by, there's more of a chance for more of them to go into the wall and start that inflammatory process, make it even more porous in that spot, make more go into the wall and build to this plaque.
So the NMR lipoprofile does that, looks at the number of particles.
Yes.
And then the ApoB, because there is only one ApoB molecule per particle, is that right? So that's why the number of ApoB also gives you a rough idea?
Yes, the ApoB is also counting up all the ApoB containing lipoproteins, which includes, your LDL, your VLDL, and your chylomicron remnants. And so that's why it's becoming this popular measure of risk, because we know that it's these ApoB containing lipoproteins that can enter the wall and cause that plaque to form. And we know that it's not just LDL, but also these remnant cholesterols that can, like we talked about, remnant meaning we've taken some chunks out of it.
Yeah.
These remnant cholesterols that still have ApoB and have a causal effect for cardiovascular disease. We've proven that now.
So one thing that I wanted to ask you, we talked about how statins work. Then there is this new class of drugs that came out a few years ago, PCSK9. Can you tell us a little bit about what is PCSK9 class of drugs? What do they do?
It's a very powerful class of lipid-lowering drugs, and it works in a different mechanism from the statin. And they discovered it, I think, interestingly, in that there are people who have a genetic defect in this enzyme called PCSK9 that acts like a Pac-Man that eats up that LDL receptor. So it interferes with your filter in the liver.
Yeah, I see.
And the people with the mutation have a dysfunctional Pac-Man that just floats by and does nothing. And the filter just gets to keep removing LDL from the blood. So they thought, why don't we create a drug that specifically is an antibody that targets that Pac-Man, jams it up, makes it dysfunctional, and makes it float by. And that's what the PCSK9 inhibitors do.
Yeah.
And it turns out they lower cholesterol over 50%.
Wow.
And they decrease major adverse cardiovascular events. And even in the long-term outcomes study, they showed us that the earlier the better, the lower the cholesterol, the better, and that there even may be an all-cause mortality benefit to this. So pretty powerful drugs.
So you said PCSK9 reduced cholesterol by 50%, almost by half.
Yes.
Instead of, for example, suppose take a hypothetical patient who has, say, LDL cholesterol, say 200. So PCSK9 would bring it down to hypothetically 200. How much statin would do?
Rosuvastatin 20 should also bring it down pretty significantly. I would say about 50% as well.
That's pretty high dose of statin.
Okay. Yes, rosuvastatin at the highest intensity.
Highest intensity. But then the regular statins, they'll bring down what, 20-30%?
Yeah, about that. And everybody's different.
Everybody is different, yeah.
But, especially women tend to be very responsive. So between the statin and the PCSK9, with someone with an LDL of 200, we potentially can start to inch them towards, if we were being most aggressive, that goal of less than 55, which is now in the AHA-ACC guidelines for most aggressive treatment for a very high-risk patient.
I see. And then are there any other new drugs that are in the pipeline? Because I also hear about lipoprotein Lp(a). What is that one?
Yes. Yeah. So Lp(a) is another ApoB containing lipoprotein. And it also contains apolipoprotein A.
The small a?
Yes, small a, little a. And it's an ApoB containing lipoprotein. It's just as dangerous for the arteries as LDL. And it's primarily genetically determined by a single gene, and the LPA gene. And so it's an interesting lipid, and it's one that's not really affected by the lifestyle.
I see.
It's mostly determined by your genes. And so 50 and above is where that becomes more dangerous.
So that means if it is genetic, then if someone is there a test now for Lp(a)? And should teenagers, young adults should get tested, because if they can catch it earlier, then they can manage it better?
I definitely think so. I think, 18-year-old, you should be getting this lipid panel, especially if there's a lot of history of coronary disease in the family. That's a kind of key into getting this checked out. But definitely it's recommended all adults have the Lp(a) checked at least once. And I think the earlier, the better.
Yeah. Okay, so that's another one that everybody should get tested at least once. And then, as you said, this is not affected by lifestyle that much. So that means you don't have to check every single year, but at least once, and you should know your number.
Exactly.
Number.
Yes, it should be relatively constant throughout your lifetime.
Yeah. Okay, so we kind of diverged a little bit because I remembered PCSK9, but we are talking about calcium and plaques. We talked about this coronary artery calcium score, or CAC. How frequently one should get that done? Once in 5 years, 10 years?
So I kind of weigh the radiation exposure and how much it will be useful. But it's good it is recommended to potentially be repeated after 5 or 10 years. But something that you can also do that's no radiation is to look at the carotid. So oftentimes I will do that and look for plaque in the carotid arteries, because there's no radiation with the carotid ultrasound. And there's good data behind the carotid ultrasound for prediction of MACE, major adverse cardiovascular events, as an independent predictor outside of the calcium score. And there was even a recent paper that's just coming out looking at the MESA database from calcium scores. And they looked at people with calcium score 0 and how many of them progressed, which they found quite a few of them progressed quite quickly to actually have a fair amount of calcium on the coronaries. And what risk factors did those patients have? One of them was carotid plaque.
Oh, so what is this MESA database? Sorry.
Oh, it is a very large database and famous database in cardiology of patients who have had calcium scores.
I see.
And so a lot of really good studies come out of that database because they have had maybe some of them have had repeat calcium scores. They've had a bunch of labs done. And so we get some really good, had this database for quite a long time. We get good outcomes data from it and things. So it's a very...
So the carotid artery ultrasound, how does it work?
So I actually had some of the vascular trained sonographers at Scripps teach me how to do it. And it turns out it's a very quick protocol. And so you basically scan up and down in short axis and you look for plaque first in short axis. And the plaque is pretty easy to visualize. It just looks like almost little pebbles where it should be a very clean and crisp artery wall. You'll see it just looks kind of, so you can see like almost pebbles there on the surface. And then you find the bifurcation where the carotid artery splits into two. And there you go into short axis and you'll see a bulb, the carotid bulb, where it kind of bulges out and then it bifurcates. And that's where plaque is most likely to form. So that's the most important spot to visualize. So I'll go in long axis there and look for plaque visually. And then in order to visualize soft plaque, you put color Doppler, which is an ultrasound technology, and you want to see the color from the bloodstream moving, going all the way out to the edges to make sure there's no soft plaque there.
I see. So you have the ultrasound here?
I have it here.
Okay, so we can do it.
So this is the ultrasound. It's one of the handheld ultrasounds that's available and pretty fun to have this technology. The whole entire ultrasound machine contained in one probe. And so we can use their vascular access setting to get a pretty good view of the carotids. And so we'll look in short axis here to start. And there's the carotid. So we'll go all the way up to the bifurcation, which for you is way up here. And look for plaque in the short axis, and I didn't see any all along the way up. The most plaque builds in this bifurcation spot. And so we want to see the bulb, which basically looks like a bulb. And I'll record this here. And then I can tilt it here to get an angle for the color Doppler. Add color. And this will look for soft plaque. We want to see the color extending all the way to the edges of the walls. No plaque there.
Wow, that was like less than 2 minutes.
Yeah, it's very, that's the crazy thing. I want to build an in-clinic protocol for abdominal aorta and carotids because it's so quick and it's no radiation and it's such a quick risk assessment tool. But so one thing they'll be able to do on the formal ultrasound that I can't do with this is that they measure your intimal medial thickness, which has had some data for risk prediction. They'll measure it kind of in millimeters, how thick the walls are. And if you're having earlier thickening, then that is a potential risk of kind of early plaque formation.
Yeah.
But they can also measure, if there is plaque, measure the diameter, and some more advanced ultrasound technologies, they can measure the volume and use that for risk prediction.
Wow. So this is something that anyone can get in every 4 or 5 years and then see whether, because it's not going to build in 1 month or 1 year.
Exactly.
It's not going to reverse also in 1 month or 1 year.
It's something that we can repeat over time to look for progression, and maybe something that you could reach for before repeating a calcium score because it's less radiation risk.
Yeah. No, this is really fantastic. I had no idea that it's so easy and quick. And, it's always the case, like seeing is believing. If you can show someone the image or the video that this is how your plaque or your clean artery looks like, and try to keep it clean. Otherwise, if you have an example saying how a unclean artery looks like, then that actually motivates people much better than just a number.
Yeah, I agree. I think I always love to look at these images with my patients and look at their cath films together, look at the carotid films, look at the plaque, and it is something meant to empower, because still this is a risk prediction tool. I'm not telling you, I'm not looking for major stenosis. I'm looking for early plaque development. And this is something that can motivate us to make a change so that we can reverse it and prevent progression. Yeah.
Super exciting. I mean, in this episode, we kind of went really all the way from when we eat something, how that fat and cholesterol gets absorbed and how it's chewed in different parts of our body. Liver takes it up, then reprocesses it, brings it back, and then how inflammation and lipids, proteins, all of these work together to build up plaques, and then how it affects our overall health. And I guess this is the most exciting part, that you can actually look at, because I always say that seeing is believing, and seeing also empowers, as you said. So thank you so much for another exciting episode, and maybe we'll continue again with what people can do, because we went through what is the science and what test people should be doing. And maybe in another episode, we can discuss what people can do, starting from diet, exercise, sleep, supplements, medication, and other stuff to stay healthy. Because at the end of the day, heart health is the heart of your health.
Yes, exactly.
Thank you so much. And hopefully we'll have Dr. Liz Epstein again to go over another episode. I'm your host, Professor Satchin Panda. I hope you learned something new and found this episode exciting. If you did so, please leave us a comment. If you like the science that we discussed and would like to make a donation to research in my lab at the Salk Institute, you can do so by going to panda.salk.edu/giving. Thank you again for listening, and I'll see you next time.